No, we go. Okay. So, good morning, everyone. I will talk just on the brief approach on it because toxicology is a very huge topic. Every different toxic or toxin or the poison got different antidote, different their own specific characteristics. So it's difficult to go through one by one. So this is just a basic clinical approach. At least you know all this. Because most of the toxic case you can manage supportive management. So at least you know the basic approach is enough to do no harm to the patient and support the patient until you get further information or consultation to other teams. So first, before we go into the topic, so this is Paracelsus. He's the father of toxicology. What he says is everything with us is poisonous. The thing that it just depends on the dose. So anything that we eat actually is considered poison also, but we won't get poisoning because the amount we take is not large enough. So for, let's say the most toxic thing in the world is botulinum toxin. Is your Botox, the aesthetic Botox. In just a very low dose, 1 nanogram per kilo can kill a person already. There's how the patient eat a canned food and get the botulinum toxin and come with respiratory paralysis. So it's just a very low dose. So this is a very low dose. The high dose one, vitamin C also can kill, but you need to take up to like 10 grams per kilo, which is a lot. No one is going to take that. Your salt, your garam that you eat during cooking also can kill, but you need like almost 1 gram per kilo. It's impossible, right? You are 60 kilo, you take 60 grams of garam. That one you die also. Then you can see ethanol is there also. PCM is also there, but PCM dose we know is 150 milligrams per kilo. So all this, everything is poisonous, just depends on the dose. So now I just show a few of the poisoning. Toxicology actually not only for poisoning, also including bite and sting, plants and herbs. So the plant and herb, the most common is mushroom. This mushroom, you still remember Alice in Wonderland? This mushroom is in Alice in Wonderland. It's Amanita muscaria. So inside the Alice in Wonderland, they eat this mushroom and got hallucination, right? It's correct. He affect the glutamate. He got he can initially cause children usually we have agitation or these things, but adult will get CNS depression, hallucination, or this effect. But not common in Malaysia. We don't have much Amanita, but we got other species of Amanita found in Malacca also previously. This is the common one we see here. The whole Malaysia also, some people will go and pluck and eat beside the roadside after rain. Because I think certain people will heard the teaching before, like mushroom which is white color is safe to eat. Red color don't eat, white color can eat. That's why they go and pluck and eat. It's nice to eat, but this is not safe to eat actually. The taste is good. This is chlorophyllum molybdentis. The only effect is GI returns if you come with AGE. So if you can bear the AGE, you want to test, can. The taste is very nice. I asked the person, they say very tasty actually. The tastiest mushroom they eat before. Not very tasty. But I never try. I don't want to get it. If you all want to get MC, at least you can try. Won't have much effect, just AGE. Unless you get severe dehydration from AGE. If not, it's fine. So the management just supportive only. The symptom is very fast. Half an hour after you take the mushroom, you start having AGE. This is the one that I show this one because this one is the one that if you don't like someone, you want to make someone die, you can eat this and no one can die. Because the effect is 3 weeks later, 2 to 3 weeks later. The patient will come to hospital, doctors will treat as, renal failure for investigation, don't know what is the cause. Septic shock secondary to renal failure. And with renal failure, that's it. It's a nephrotoxic. It's a oralanin group. It's a Cotinarius oralanus.
What is this?
This one don't have. This one don't have. This one don't have. This one I just showed it. But now because you can buy online, so someone can just buy it. Shopee is wonderful now. You can get anything from Shopee. So if you eat this, initially you have some GI symptoms, but after that you will be fine. Maybe a bit of AKI, but not serious. So no one will go to see doctor. 2-3 weeks later, you start to have acute, very bad, severe renal impairment, uremia. Then they will see doctor. But of course, we won't get the history like the patient got eat mushroom fried rice 3 weeks ago. The patient himself also won't tell the doctor, 3 minggu lepas saya ada makan nasi goreng cendawan, tak mungkin kan. So it's like always mysterious death lah.
Oh, 3 minggu.
2-3 weeks lah. Delayed is a delayed nephrotoxicity. It can be up to 2 to 3 weeks. But if you eat a lot, then maybe within 1 week. It depends lah. No, presentation there is acute renal nephrotoxicity, acute renal impairment. No, ini tak ada kat Malaysia lah, kecuali dia beli Shopee lah. This one is common lah. Tatura. Jimson Reed. It's not mushroom, this is Tatura, that's a plant. This one also common, right? Morning glory. Can. Some people go and eat, but the flower itself don't have. The seed is poisonous. The seed is similar to the substance abuse LSD. Can cause hallucinogen. The seed can have this effect. So if you don't dare to try ganja, you can try this. The seed, you eat the whole flower together with the seed.
That's the seed only.
No, because you eat the whole flower, the seed is inside also, ma. Then they go and check lah. They go and do research. They found that the LSD, similar to LSD component, actually inside the seed, not the flower bitter. Inside the seed.
So kalau hanya bantu air dia jadi biru tu, no lah.
Because you the flower bitter only, ma. The seed is not there, ma. So okay.
Flower tak apa.
Flower dah.
So tak boleh kadu ikut ya. Nanti tak boleh.
The seed.
Makan cepat ni saya galau.
So this is some of the plants that got poison lah. Yeah. Durian. Ini bukan durian. Ini dah. Bukan, dia besar macam ni tu. Besar macam ni je. Tak. Kecil je. So this is for plants. So another thing is anything inside our house can be poisonous also. You see you go to KL, all these places, they drink Clorox, then they take pesticide, racun tikus, all these can. Even then other is the medicine. Children is the worst because children cannot differentiate. If I didn't show you the name also, I don't think we can differentiate also. Which one is gummy, which one is what. So it's difficult. But kids usually they take a bit only lah. But there's some medication that even the child take 1 pill can die. That one I will show later. So after that, toxicology cases can be disaster also. This one, the picture not from here, but there is a similar case happened in Malacca a few years ago. What is this gas? Still nobody, right? I saw the same picture during the 2 days ago the course. Yellow, green yellow case, green yellow. It can be yellow, it can be a bit greenish. Chlorine gas. Chlorine gas. Because chlorine gas in Malaysia, we got a few factories there. Malacca also got, Salam, Selangor also got. So sometimes you have gas leak, then you can see. But this is easier to see because you see the color. So chlorine gas, at home you can create also. At home. You can create chlorine gas also. You take Clorox campur. Batu lain, which contain acid. So any sodium hypochlorite, your chloride is sodium hypochlorite. So you campur with like tile cleaner, floor cleaner, they are acidic, right? You campur together. If the concentration reach already, you will see the yellow gas come out. Don't try at home lah. We don't want to see you here. That's why the label always put there, do not mix. But certain people like to mix. I don't know why. Malaysia like to mix. Malaysian. Makan semua mix juga. Curry pun semua mix. They pun mix lah. So they mix. So come to hospital with SOB. So this is another case. This happened in Sabah, but also happened before in Selangor. This gas is white color gas got a lot lah. But Malaysia one most common is ammonia gas. This plant is in Sabah. This picture is the Sabah case in 2016. But after that, got another case in Shah Alam also. So this one is the most recent one. Before COVID, just before COVID. In Johor. Sungai King. Oh, Sungai King.
The ambulance arrived first and then the driver passed away.
Driver passed away, they don't know good.
Kan dia intubate kan?
Intubate because the gas, they got a lot of pollutants inside. It's more than 100 type of chemical. But the most dangerous inside there is cyanide, the type of chemical cyanide. Then they got other hydrocarbon gas like benzene, methane, all these also there. But the most dangerous at the time is the hydrogen cyanide. So how poisoning patient die? Usually two main mechanisms only. Either the patient die from CNS effect or CBS effect. Depends on what poison. If CNS effect, how they die usually is either intractable seizure, they cannot not responding to any antiepileptic, or the patient did coma. Then got airway obstruction, UK aspiration. Then cardiovascular wise is either cardiac arrhythmias because of prolonged QT or widened QRS. Then after they develop your VTEF, or refractory hypotension because of some of the medication they got alpha blocking effect. So it will have very severe hypotension, which is not responding to fluid because it just causes peripheral vasodilation. Then others is pulmonary fibrosis. This is renal failure, this paraquat. Hepatic failure or the liver toxicity. Most common is PCM. So the approach same lah, ABCD, DIBCD. After that, take the history examination is the same as what we carry out every day. Just after we do the physical examination, if you can group it to become toxidrome, it's better. There's an extra thing here. Then your basic investigation. Then after that, if you can do decontamination, you can do. Then if got antidote, then see whether indicated to give antidote or not. So first, before you go and touch those patients, protect yourself first. But no need to wait until like this. It depends. If you wait until like this, means you want to go to the scene. But usually those are asthma people. Asthma people will clean the patient off, like what they do. That is the Tokyo sarin gas incident. So, but initially when the patient got the symptoms, some of the patients didn't know, just straight go to hospital. Doctors also don't know, nurses also don't know, they straight will touch the patient. So they also cannot poison by the OP. So at least decon by the asthma when they send to hospital, we need to use our usual PPE. There is enough. So resuscitation is the same, ABCD plus C got seizure, control seizure, but the control seizure is here because toxic cases, you want to control the seizure, only benzodiazepine. Don't use phenytoin, don't use sodium valproate, all these will cause more harm. You can choose benzodiazepine. If cannot, you intubate also high dose midazolam, all these will continue. If still seizure, can use phenobarbital. Then after that is your propofol. All these are safe. The rest like phenytoin, Keppra, all this is not, won't be useful, and phenytoin will cause more harm. Keppra no harm but it's just the Keppra no effect. The mechanism is different, so no effect. The phenobarbital and is useful because phenobarbital and benzodiazepine both same mechanism. They go through your GABA receptor, the benzodiazepine and phenobarbital. So these two are safe to give. So the history part, first you ask if the patient is aware, you can ask he got exposed to anything, or he himself intentionally ingested something, or he eat something. Then the time is important because if eat 1 month ago, then usually nothing. On the only long-term one is like paraquat. That one can be long-term, but very few is long-term. Most of it is very short-term, very acute. So the time of injection is important. Like the patient told you 1 week ago, he take PCM 20 tablet. Is it important now? Now no symptom, no jaundice, nothing. It's nothing. Maybe you can take 1 LT to see got any hepatic injury, but usually nothing. So the time of injection is important. The dose, how much it take, 4 tablets and 10 tablets. What is the difference? These are the dose is different. Intentional or unintentional, this is from history part. Because most of the tox cases are medical legal. Sometimes you feel very suspicious, like the patient say, oh, I accidentally drink the Clorox. How can you accidentally drink the Clorox? Got smell one. Sounds very fishy. Just refer psychiatry. They will get a history that actually patient got some stress. They want to kill himself. He just doesn't want to reveal to you. So be careful with all this history. Sometimes they tell you it's unintentional, but actually it's intentional. Most of the time it's intentional. But I have to think logically because just like the case that got color changes, got smell, how can you mistaken it? So for kids, usually accidental. Accidental usually present very early. They won't wait until 2-3 days because the parents will be worried. Accidental. But it's mostly take a bit only. Because kids usually they will test first, right? They won't straight away makan, right? Not like us, just makan. They will test. If not nice, they will throw away. If nice, then only they will put in the mouth. So usually just a bit only. But there are some medication which are one pill can kill the kid already. So all these, some of it quite common, like nifedipine is also in the list. So the kid take one pill of nifedipine is very dangerous also, but for adult it's okay. Then the miscellaneous here got one is camphor here. The camphor is your mothball. Mothball. Ubat gegat, the camphor. But nowadays you won't see ubat camphor type of it anymore because too dangerous. They changed already. Now change to naphthalene. But there are even more safer one, paradichlorobenzene. But it won't usually label there, so you can do some tests to differentiate. You can do the floating test to see which type. Let's say if the mother bring a child to you, say the child was playing with this, unsure taking in or not. So you also want to monitor, but you don't know what it is. Just take the water and D50.
Water and
D50.
D50.
D50 is more denser. Then water is just water.
Yeah.
So you take the mothball, put inside the D50 first.
Okay.
If it sinks, tenggelam, that is paradichlorobenzene. Safe to discharge, nothing much. Just can straight discharge already. If it float, then you have to take and put in the water, normal water. So in the normal water, if it sinks, then it's naphthalene. Naphthalene, the effect is hemolytic anemia. Hemolysis, but it's delayed. So you may need to admit for monitor for at least 24-48 hours. But if the child is well, some center like Hashta, we actually discharge the patient, ask the patient to come in 2 days time to check again. No, tenggelam in water. Float in D50, tenggelam in water. No, float. Tenggelam in D50. Then and also have to ask the parents about the GCPD status.
Yeah.
GCPD deficiency very prone to hemolysis, so the hemolytic will be very early. Then if it's float in both, means float in D50 and float in water camphor, you have early onset seizure. Usually very early, within 6 hours you have seizure. Okay. So intentional usually is adult and young adults, our teenagers nowadays. They feel stressed and take medication or to tell, and most of them sometimes present late. If not found by family member, they will present late. So recreational also can, like the rave party in KL last time. You all remember a lot of they got a party, then the HKL got a lot of patients all come with very agitation, restless, rhabdomyolysis, all these recreational drugs. Yeah, here Ketu never mind. So criminal also can happen. Like I want to kill someone. There is a case in China. This in China, 38 died, hundreds admit to hospital. So what he did is because they got two shops. One guy, restaurant, very good business. His restaurant, the business not good. So he go and put this racun tikus to the food ingredient of the rival one. So suddenly the next day, hundreds of customers all suddenly go to hospital for seizure. Seizure. This one in Chinese is racun tikus strong. Another brand is this one. You smell and you die. So it's very fast. This one is very, the ingredient is tetramine. It's banned in the world already. So if you buy this from Shopee, you will realize that there is no label about ingredient behind because it's banned.
Sorry, shopping.
If what you want to do? For your husband? But if you buy the King Kong, all these, they will write warfarin base there, right? They also got label. All the Russian tickles got label, like zinc phosphide, label, but this one no label. Because it's banned after Tramine. Very dangerous. And this year in Klang, we got a case also. Suddenly, the Pulau got a few family, no matter what age, all come with seizure.
Last year yang bertusuk hati, Pulau Ketam,
here we take the things, the water there to check already. The Palangkina check is the Tramine. So it's the Tramine. Also can get because of Shopee, you can get Shopee, so you can get this product.
Dengan lot.
So these are the history. Physical examination is the same that what you do every day. Your neurological examination, the basic one, from eyes up to the abdomen, the important of vital signs. So your pupils will tell you some clue lead to your toxidrome, and one important one is bowel sound. Because most of the medication they got anticholinergic effect, so it will slow down your bowel movement. So when it slow down the bowel movement, the patient might appear well first because the absorption is later, is delayed. So it might start, there is a latent period like that. So bowel movement is very important when you the tox case. If the bowel movement is normal, then you can use your textbook time of onset of this because it's easily because the movement and the absorption is the same. So you can use your textbook time, like they say 1 hour you get absorbed, that is correct. But if the bowel movement is already reduced, you cannot use the follow textbook anymore because you don't know when the patient will have delayed absorption. So it's very simple. All these examinations will lead to toxidrome. So the toxidrome is just a syndrome of signs and symptoms.
Lagi sekali potential that part yang bawah movement punya part.
Bowel movement, like when you read the book, it will say metabolism is 2 hours, elimination half-life is 8 hours, all this, right? All this is after absorption, right? So if your bowel movement is normal, then you can still follow this. How many hours, the timeline. But if the bowel movement is slowed down already, already delayed absorption. So it might not follow because the symptom might appear later. Like you read the textbook, they will say onset of symptom is 30 minutes. But if there is reduced bowel movement, the onset can be 2 hours later because of delayed absorption. So bowel movement is very important in your management.
Lepas ni kena dengar.
So after the physical examination, you can combine the group of signs and symptoms to become a toxidrome. There are 5 main toxidrome, cholinergic, anticholinergic, symptomatic, opioid, sedative, hypnotic. So first we will go to cholinergic. Cholinergic is the sarin gas, nerve agent, or P poisoning. This is cholinergic. So the most recent use of nerve gas is during the war in Syria.
No, the most recent use is the KIA one.
Oh, no, KIA one, this one. No, this war, this for war. I say for war, for war, big one. For war. And terrorists used in Japan. This one actually we say is nerve agent, but it's suspected only. No one prove it. Cannot prove. This one at least proven. This no one can prove. It's just based on the signs and the onset of the suspect is OP lah. It's a nerve agent VX, but no lack proofment confirmation. So cholinergic lah. So you know cholinergic can be muscarinic or nicotinic because all involve your acetylcholine. So acetylcholine is you can found in your muscarinic receptor and nicotinic receptor. So the sign and symptom can be either muscarinic or nicotinic. So this is the mechanism. I think no time to tell, but it's okay. It's just excess acetylcholine. The outcome is excess acetylcholine. So it can cause muscarinic symptom or nicotinic symptom. Commonly, the patient will come with muscarinic symptom. Like OP poisoning usually come with meiosis and very wet. But sometimes you will see nicotinic symptom because it depends on what receptor. So How to remember it? Muscarini, I think everyone will know lah, sludge. Nicotinic is this, but it's quite easy also because it's actually Monday, Tuesday, Wednesday, Thursday, Friday. So this is the nicotinic symptoms.
Saya ingat masa itu, saya tak ingat kau ada
So, but the one that kill the patient is not these two. Either these two might appear early, like the patient will come with salivation, urination. That time you should take action already. If you didn't take action, they may go into this. Bronchoria, bronchospasm, bradycardia. These are the ones that kill the patient. That's why it's called kill the beast. So the management, semi-supportive. Antidote, because we give something anticholinergic, which is atropine. The easiest to find, atropine. So the dose you can give 1 milligram, then after that doubles every 3 minutes until the secretion is dry. The dry, you cannot just see the skin. The skin, you have to see the axilla. Axilla is the most wet one, right? So you have to see that. Axilla. Then the pulse is bradycardia, at least you reach target of 70 to 80. The BP also improve. So this is the target. No need to aim for the pupils from meiosis to become reactive. They want no need. So a lot of textbook initially they will write there. While the target is until the pupils become no need.
The pulse pun 80 je cukup dah.
Enough already. Actually, sometimes we 60 plus 70 also okay. We see the symptoms also because the patient bradycardia sometimes with cerebral hypoposition will be a bit PD, but if the heart rate improves, the patient also improves, that should be fine. Then you can start with the infusion. Infusion is at 10% of the total dose of the atropine they will use. Then seizure control, as usual, is just use the benzodiazepine. For those cases, benzodiazepine first. You can give until high dose also. No need to follow the usual status that critical say that you give 2 times, maximum 20 milligrams, then you have to start phenytoin. No need to follow. For those cases, just benzodiazepine, whack them. So next is anticholinergic syndrome. This opposite of cholinergic.
Because usually there's what 30 milligram then you stop kan, you tak bagi kan.
You just continue.
Bagi je.
Bagi je. I could give up to 500 before.
Oh yo. Tapi secure airway, everything semua tu you kena care.
But usually if you cannot control with the initial one, you can straight away go for intubation. Then you can start high dose infusion. Midazolam, usually intubator you give like 4 or 5 milligram per hour, right? You can give 10, 20, 30, 40 milligram per hour also can. Just to control it. But of course, you have to stop the activity. Sometimes you have to add in propofol or phenobarb. Don't the main point is don't give antiepileptic. Don't give the usual antiepileptic like the phenytoin because everyone will follow. Hey, your benzodiazepine 20 milligram diazepam fail already. Phenytoin start. That one maybe the patient will die. If the patient is having sodium channel blocking agent toxicity, like you take the tricyclic antidepressant, they will give phenytoin. So it will go into the anticholinergic. But usually because the benzodiazepine, their action is they still need our own body GABA receptor. You still must be activated. Then the midazolam benzodiazepine can add on. Phenobarb can bypass it. Direct acting on the GABA receptor. So that's why phenobarb is, if you benzodiazepine, you give a bit high dose, you worry, you can use phenobarb to stop the seizure. So anticholinergic, opposite of cholinergic, datura is here. That's not a datura, it's something very small. Then our antihistamine, your piriton, cetirizine, all these actually can cause anticholinergic syndrome. So antipsychotic also got a lot. Antipsychotic got a combination of action. It can alpha antagonism, anticholinergic. Or some of them got sodium channel blocking, some of them got potassium channel blocking. It depends on the agent also. And main effect is dopamine antagonist for the antipsychotic. So muscarinic receptor, we actually got 5 M1 until M5. But M4 and M5, the effect is very minimal, so not so important. M4, M5, both also in CNS. But the CNS main effect is actually M1. So you can have central anticholinergic effect. It's mainly through the M1. M2 is the heart. That's why you get tachycardia, all these things. M3 is the smooth muscle, like smooth muscle in your lungs, the airway, your bowel. So you can have bronchoconstriction of this. So the patient is this is muscarinic activation. So you empty all these things. So the patient will come with the saying they always heard one, right as a bomb, red as a bead, all this. So but if you cannot remember, it's okay. You just remember one enough. Remember cholinergic. Everything opposite of cholinergic, anticholinergic. So the management is still supportive. So if the patient is restless, don't use halo. Because haloperidol is antipsychotic, right?
Yeah.
It's anticholinergic. So the patient already anticholinergic syndrome. You give some more. So it's dangerous. So actually a lot of still benzo. A lot of places actually they don't use haloperidol. Like starting in Glen, we never use haloperidol. Total Anissa in Malacca already banned haloperidol. Never use. I also almost 10 years never use haloperidol.
In the psychotic
I just use diazepam. You never know what they take. Because they come with psychosis. Do you know what they take? They cannot tell you also. They eat anything they get found on the road. So you never know. So sometimes you give already, they are more agitated. They thought it's not enough. But actually, it's because you give more. So the safest is still just use benzodiazepine. The antidote is picosamine, but no need to use that. Most of the time, you just need to give benzodiazepine to control, supportive, they can get rid of it. So next symptomatic, this is one of the most common one. The shabu, all this is from ice, amphetamine, or symptomatic. So the presentation, I think all of you know, like is your sympathetic effect, your flight or flight response. So the difference between sympathetic and anticholinergic is just diaphoresis and novovaltol. Just now your anticholinergic also got tachycardia, hypertension, mydriasis, all this, right? It's similar to symptomatic, but you listen to the bowel sound, then you can find the difference. You see the skin. Anticholinergic is dry. Symptomatic is sweating, profuse sweating. Then you can difference from anticholinergic. So the management also supportive for me. See, everything is supportive, quite simple. It's just some medication that we usually give, just make sure we don't give this enough. Main thing is just a benzodiazepine also, but in symptomatic, what we need to treat is hyperthermia. Hyperthermia is directly related to mortality. So hyperthermia is the main cause of mortality. So if the patient got hyperthermia, cool the patient, aggressive cooling. If you got fan, you can blow the fan. But already is cold enough, so should be okay. Then your drip, like trauma case, you see warm saline, right? This type of patient only warm saline, just a usual very cold one also can. Just give them want to cool them down fast. If really cannot, then you have to go internal cooling, which is like you insert the NG, gastric lavage with cold saline, or bladder irrigation with cold saline. So for this type of cases, why we want to stop this, because this will eventually lead to rhabdomyolysis. So this type of patient have to monitor the IO very.
Actually, I was testing.
Sorry, hello.可以 admit 吗？他带 document 来就可以 admit 了。要有那个，他有那个 document 可以 admit，然后过后 specially 签，然后要本来他也知道的。2个，anesthetist 跟你。不能 send department，不能 send department，要 go to office，要跟 office 讲，本来的 office，就是这个 patient 在 case 推荐给本来的，OK，OK， sorry， admin issue。So okay, so the last is the second last is opioid toxicology. This sometimes we will see these type of cases also because some of our patients they are on methadone, right, for the withdrawal for opioid toxicity. So sometimes their kid, you see the methadone. Methadone is very nice color, orange color. So they thought it's something nice to drink, so they take and drink, then drowsy come to hospital. Most of the cases are like that. But sometimes you will see some patients they really purposely take a lot of methadone. I got a patient take 2 bottles of methadone also, come to hospital. So their main things is they will have coma, the one we know because of CNS depression, bradypnea, respiratory depression, and meiosis. So these three things are there. Think of opioid syndrome first. A lot of people will think that benzodiazepine also cause all these, right? But benzodiazepine won't have so bad respiratory depression actually. If you all got take MK paper or FRCM paper or MRCP, there are questions sometimes they will put the patient was found with all these three after go to party or something. Then what is the thing that you suspect the patient is tested? They got ABCD there. One of you benzodiazepine, one of you will be opioid. The answer will always be opioid. Because for benzodiazepine, the respiratory depression incidence is actually very low. The risk is very low. No need to be so worried about respiratory depression for benzodiazepine. Opioid is even higher. A lot of people will think MIDA is more dangerous than morphine. Sorry, morphine is more dangerous than MIDA. But our thinking always think that MIDA is more dangerous. I want to do PSA, give MIDA also so scared. But give morphine, give like water. But actually it's the other way around. Morphine is more dangerous. So that's why if you give fentanyl plus midazolam, your fentanyl is more dangerous than MIDA actually. So our main aim actually not to reverse the meiosis. You just need to reverse a bit of the comatose status until the patient can maintain airway and reverse the bradypnea. No need to reverse until the patient fully aware. That's our target. So the patient will come like this. If you suspect like the child, the father said not sure he got take the methadone or not, but the methadone bottle was empty. Some are on the floor, but you're not sure. No need to take urine from the kid. Okay. The UDT is not accurate at all. Because our UDT, our 5-panel one, they only detect natural opioids, which is your morphine. The synthetic opioid, fentanyl, tramadol, methadone, won't detect. Sometimes you can detect, but most of the time you won't detect. Standard. Because the metabolite they detect is different. That's why the cannabis you look on the urine drug test, they look at the THC. Because that is the metabolite. They won't test for the mother compound. They test for the metabolite. So the reversal supportive, naloxone. But if they take a bit, then he come here, let's say GCS is 13, respiratory rate is 18, just let them sleep on it. We are supportive on it. No need to reverse. Because reversal is with risk also. Because especially those we don't know the status. If kids, they okay. If those adult, we don't know the status, maybe he is a chronic opioid abuser. You give the withdrawal, it can trigger the withdrawal effect. The patient will suddenly, because you withdraw the effect of the opioid on him. So he will suddenly wake up very agitated, want to look for drugs, just like they got the dependence and withdrawal effect. So for those patients, usually we will start very low, 0.04. So the dose is like this. If those for not opioid dependent, which is opioid naive, you do PSA, you accidentally give 10 mg of morphine, and the patient bangs on, then you can try your 0.4 mg naloxone. But if the patient you unknown status, or you know that she is an opioid abuser, you start very low, 0.04. Then after that, followed by 0.1. You titrate to see because you just want to reverse until the bradypnea is not there. Reverse the bradypnea. So there's
just assume that they are opioid dependent.
Assume it's opioid dependent. It's safer. But if you give a lot already, like let's say the patient come here, got that 3, let's say it's a bradypnea, meiosis, deep coma. But you give until high dose already, it still never reverse. It may have core injection or maybe other causes, maybe brainstem stroke. Cannot be too judgmental that this patient is ex-IVDU, confirm is drug. Who knows he got brainstem stroke? The one we never know. So sometimes you can try, but you have to look for other causes as well. So the pediatric dosing is different for naloxone. This is a bit special for the antidote, because most of the antidote is milligram per kilo is fixed up. But for naloxone, it's a bit different because the dose, you follow milligram per kilo, but for pigs, you can give higher. So before that, except for neonate is different. Newborn, they follow the NRP. The mother is opioid usage, or you give petidine or this. They got their fixed guideline already. They want just follow. This is for those more than 1 year old. The toddlers accidentally take methadone or this thing. So the dose is a bit different because before that is 0.01 milligram per kilo. If you look at Frank Shan also using 0.01 milligram per kilo. But actually you can use 0.1 milligram per kilo. This is by American Academy of Pediatrics. Actually back in 1990 already changed. Because they found that there are studies that some case report that they give until as high as 0.4 milligram per kilo, but the child has no adverse reaction from naloxone. So they fix it at higher dose with 0.4 milligram per kilo. Because for PITS, you want to reverse faster. PITS is respi arrest, respi is more important. So you want to reverse it fast compared to adult. So for PITS, your dose is like this. If less than 20 kilo, 0.1 milligram per kilo IV, except for neonates, as I mentioned just now. More than 20 kilo, you can give 2 milligram IV stack dose. Then after that, repeat. So our PITS protocol also mentioned the same thing like this. Our PITS protocol also mentioned the same thing. So for naloxone, cannot follow Frankshan. That is the only thing. Frankshan, you can follow everything except for naloxone. Naloxone, because they are still using 0.01 milligram per kilo. But actually, you can use 0.1. So for sedative hypnotic, this is our benzodiazepine. There's one thing here is chlorohydrate. Chlorohydrate, we put it as sedative hypnotic, but it itself actually is a what compound? It's a hydrocarbon. It's not a usual medication, it's a hydrocarbon. And it's the most dangerous type of hydrocarbon. Our hydrocarbon, you've got aromatic. Yeah. So actually don't give to kids. Ketamine is so safe, just use ketamine. Ketamine is just the piece some that they still use. But actually it's very dangerous. It's we got hydrocarbon, we got three main types: aromatic, aliphatic, and halogenated. Halogenated is the most dangerous. Chlorohydrate is halogenated. It can, the dose, if overdose, you can get liver failure, kidney failure, cardiac arrhythmias. So can that. That's why sometimes you can see one time cannot, they give another dose, suddenly just die. It's because of cardiac, or it can happen. So chlorohydrate is actually very dangerous. It can ban, just ban, no need to use it in the department. If please want to use, just warn them first. But if they still want, just ask them to monitor closely. Make sure they don't give the second or third dose. So the effect usually just CNS depression, a bit high like that, just like that, but nothing much. Mainly just supportive, no need to give flumazenil. Same thing, flumazenil is actually no need to use at all. Now the flumazenil usage is only mainly for like, we give the kid, let's say it's a pediatric children, we want to do PSA. We accidentally give a bit higher dose, or the child is more sensitive, then got respiratory depression, then you can use flumazenil. If no respiratory depression, because respiratory is very rare in adult for benzodiazepine. But for PITS, maybe it's more, they are easier to get all these side effects, so you can use. But for other type of patient, no need to give at all. Or just wait for the patient to wake up only. Because flumazenil itself can cause seizure in those chronic usage of benzodiazepine because of withdrawal effect. Then also it can lower the seizure threshold and precipitate the seizure in certain patients, especially with those with head injury. That's why some neurosurgeons, I'm not so here, but in HDA in Kuching, they ask us to give flumazenil because they want to assess GCS. You know, after you intubate, you give the mida, they ask to give flumazenil to assess GCS. Actually, it's very dangerous. The flumazenil you give already, suddenly the patient may fit. Because it precipitates a seizure in patient with head injury. Previously, they like. Nowadays, they don't do anymore. Because they are mainly, neurosurgeons mainly from USM. So USM there, I heard the ED department there already got informed them, so should be okay. Before that, they like to use this type of treatment. Ask to give flumazenil for them to assess GCS. Like they don't trust our initial assessment of GCS. So, and for patients who got panic disorder or schizophrenia, you give flumazenil also, they can trigger the seizure. So basically, just don't use them. They are benzodiazepine only. Just give drip, support them, check the DST up regularly, make sure they are not hypo, support until they wake up. Most of the time, 24 to 48 hours, they wake up already. So this is just the diagram to show. You can find online. So after your physical examination, you identify toxic syndrome. If you don't have toxic syndrome, it's okay also, because a lot of medication, their toxic syndrome are overlapped. They can have more than one. They can have anticholinergic jump with symptomatic, all these they can jump. So we just go to our investigation. Investigation, the usual investigation, we take. After they got some specific investigation, depends on the cases. Like some cases you need to take TDM, like carbamazepine overdose, PCM overdose, you can take TDM. Paraquat, herbicide, you not sure which type, you can take urine paraquat. Even you know what type already, they bring the bottle, just send a urine paraquat. Because you are not sure someone will refill the other thing or not. Or the shopkeeper, sometimes they will be like, yeah, this one not that strong. I jump off paraquat to make it stronger. So the one we will never know. And it happened before, so just take a urine paraquat. Cholesterol level is not so important. This is for OP, but it's not so important. Clinical diagnosis is more important for OP poisoning. Then urine drug test, in certain cases only. Like I said just now, like methadone is not curate, so only in certain cases. Then chest X-ray and abdomen X-ray usually is for those body packer, body stuffer, body packer. So the severity of poisoning, it can be just possible exposure. This is like the mother not sure the kid will take or not. Just found an empty bottle, then you can try. This least severe until invariably better. This is inevitable death, confirmed die. So the management also depends on severity. So the one that we will do the most is usually the definitely toxic, potential toxic, definitely toxic, or potentially fatal. We will do a lot for the patient. If the patient is definitely going to die, just end of life care. Like the patient tell you that he drink 1 bottle of paraquat, then come COVID or SOB, SpO2 92, okay lah. Just tell the family he's going to die. Just tell the patient also, can prepare, we will do end of life care. Just comfort care until, because it's invariable fatal, confirmed to die. Just support the patient. So the management, is just this 5 steps for the management. First is stop the exposure. Because some of the product, it can absorb through the skin, like your OP, actually it can absorb through the skin, inhale also can. So if the patient drink it and splash it over the body, remove the cloth, wash the body. But of course you have to protect yourself also, wear gloves, because it can absorb through your skin also. So there's exposure termination, and usually we decon, we use water only, but it depends on product. If the product is oil-based, like herbicide, OP, they are usually oil-based. So if you use water only, it's not enough. It won't wash off. You have to use salt. Take some sabun, take some salt. Our surgery scrub, the salt also can. Just to deal with that. Water is not enough. It depends on product. Oil-based, you need to use sabun and same time. Then supportive, decon if can, antidote if needed. Then specific treatment is those like HDO, this thing. So we go into the supportive management is just the usual supportive, ABCD plus the fluid. Decon, it's just to reduce absorption. It can be external, like I said just now, you just externally wash off, or internal. Internal can be through 3 methods. Either gastric lavage, epidural charcoal, or whole bowel irrigation. So gastric lavage, no 1U anymore. The tube size is 36 to 40 French. If you don't know how big it is, just take your chest tube. The biggest one is 36 or 40. So you take the chest tube and put beside your nostril, see you can stuff in or not. It's very difficult, right? So don't do anymore. The usual NG tube is no use for lavage because the lubang is too small. You cannot aspirate out the pills. The reason for lavage that in your textbook they say within 1 hour you can lavage because you still can aspirate out the pills. But the lubang must be big enough. So there's still one case that you still can try your lavage if the patient intubated or poisoning. You intubate the patient because the patient may present late with bradypnea, bronchoria, bronchospasm, bradycardia, very unstable, you have to intubate. And because nicotinic effect, it got very bad muscle weakness, rescue paralysis. So you have to intubate. After intubate, you insert NG, right? But OP is water, liquid. You can try to flush a bit. In that sense, you can flush a bit to help a bit. Not proven to be useful, but at least you can try it. No harm to try it because you will intubate the patient in NG inserted and it's liquid form. Just try it. You can try 200 cc flush in, 200 then flush out. 200 cc flush in, flush out until the color is the same. Means no color change anymore. So, but other than that, no need to use the lavage anymore. It's already no one produce this tube, manufacturing this tube anymore. So charcoal, there's only one brand now. The most popular one is from Netherlands. Why it's called activated charcoal? Because the activation, they activate it to increase the surface area to absorb the substance. So there are contraindications also. Not everything you can give. Of course, this should be given early, 1 to 2 hours, within 1 to 2 hours. So the contraindication of this chemical temp is all this. There's a mnemonic, can search online also. Then is multiple dose activated charcoal. This means that you give more than 1 doses for activated charcoal. The indication is just this 5. ABCDQ. The mnemonic. ABCDQ. ABCDQ. So aminophylline is same as your COPD patient got theophylline, right? Sometimes they feel depressed already, they will take the theophylline and eat a lot. In that type of cases, you can give NDSC. Barbiturates, carbamazepine, these are all the antiviral. Dapsone, we seldom see nowadays because we won't have many leprosy patients now. It's mainly used for leprosy, but on and off you will still see. Then quinine. Quinine is here maybe less, is the anti-malaria. In Sabah, Sarawak, or quite a number, so we can see. So this type of cases you can use NDSC. But if you search the literature, they will say valproate, phenytoin also can use. But that one, no harm to use, but you have to make sure the indication is correct. But the one that proven to be beneficial is this 5 only. This 5 you have to start. Let's say the patient comes and tell you that he take 50 tablets of carbamazepine, and there's a proof that 5 strips gone. The patient, even though just a bit of giddiness, just start first, because you want to reduce the enterohepatic circulation, to reduce the absorption. So start early. Then how to give after the initial dose, 1 gram per kilo, usually we give maximum 50 grams. Then subsequently followed by 25 grams every 4 to 6 hours until 12 to 24 hours. Then at the same time, you have to monitor with the TDM. But before you give the activated charcoal every time, listen to our samples. Because it can form benzoa or something, pharmacobenzoa, or sometimes the drug itself, because they take a lot, like carbamazepine got enteric-coated, is very sticky. It can form pharmacobenzoa. So together with the charcoal, sometimes it can come together. Then it block the intestine. So listen to our sound first before you give. The whole bowel irrigation, this is just like a bowel pack. It's used the same thing. Give the Fortrans also. Exactly the same thing. The indication is mainly for the last one, body packers. Mainly for body packers. The body packers that didn't show any signs of toxicity. It means that the packet is still intact, not breached, not ruptured yet. And also there's no bowel injury, that peritonism. Then you can use whole bowel irrigation to flush out. Ask the patient to just see to pass out all the packets. So if it's in the stomach, you can try endoscopic removal. If it ruptured already, have to open up the stomach, open out the abdomen, do the surgical removal. So antidote, there are a lot of antidotes, so cannot go through one by one. So basically our antidote in Malaysia, we are grouped into 3 levels. Level 1, level 2, level 3. Level 1 is the simple one, like the NSE. Almost all hospital got. Level 2 is only state hospital got, like Alostar, HSP. Then level 3 is a certain zone. Like northern area here is only HPP got. Pulau Pinang. In Sabah, Sarawak is keep in Sarawak. In Selangor area is these 2, HSTAR and HKL. So this for level 3. So these are the level 3 one. Hydroscopic is level 2, sorry. Pomopizole, botulinum, antitoxin, these are level 3. So those one you can download the book. It's free online. Antidote Quick Guide. It's created by pharmacists. Created by pharmacists. And inside already Tatin and Dr. Anissa, they all go through this book also. So their name all inside, so it can be used. But this for adult dose only, not for kids. Inside this book is all for adult dosing. The kids one you still need to find other use other reference. So the specific treatment mainly is dialysis, ECMO, liver transplant, hyperbaric oxygen. These are the main specific therapy. So go through a bit of HD. What type of toxin you can be dialyzed out? The toxin must be small. Size is small. But I didn't show the size here because the filter nowadays are getting more and more chunky. The HD filter, previously, I forgot previously is how many Dalton already. Now they can bigger size already, they can filter already. So the size is cannot give a proper size here because it depends on what filter they buy, what brand they buy. The more chunky one, the bigger size it goes through. So low volume of distribution means that if you find the pharmacology, the drug is less than 1 to 1.5 liter per kilo of volume distribution, it means that it won't distribute from your plasma to the peripheral tissue. Like your adipose tissue, it won't distribute. It will maintain the plasma. So maintain plasma, they only can go to the HD machine and flush out and filter out. So must have low volume distribution, low protein binding also, because if you bind to protein, it's not going to be unbound and filter out. So what is low is just less than 80%. So it's not that low actually, but because they did a study there, less than 20%, less than 70%, the amount that filter out is the same, similar. So, but after 80%, it won't filter out much. So low protein binding is less than 80%. But there are certain drugs which has a high protein binding, but they can become saturated with the protein binding. So after become saturated, there are a lot of free unbound compound. Then those can be filtered out. Those usually are like salicylic acid, valproic acid, carbamazepine, and phenytoin. So at certain, they very easily, there's certain sets they will be from first order kinetic become zero order kinetic. Then the protein binding will be saturable also. Then in those cases, you can use the HD to filter out. So there are a lot of modalities, right? You can HD, you can have CRRT, you can use CAPD, you can use hemoperfusion. But the best is still hemodialysis. Because the thing is not because technology, it's not the volume. The faster and the larger volume of plasma that go through the filter, the better. So HD is the best. And because previously, when you read the old books, old literature, they always mention about hemoperfusion, using a special filters like charcoal filter or resin filter. This one depends on whether it's lipid soluble or liquid soluble. So, but now already no more in use because too expensive. And there are a lot of more modern HD filter which can actually function similar. So hemoperfusion nowadays, even US, only less than 1% they use for toxic cases. In China and Vietnam, they still use a lot for paraquat. They love it, but actually not proven to be very beneficial. So hemoperfusion also got more side effect compared to HD. So basically nowadays people use HD. And what is the indication for HD? Different type of toxin, different. So mainly we can follow this guideline. It's a strict recommendation. This one is formed by a work group formed by nephrologists, toxicologists, EP, pediatrician, intensivists, pharmacologists. So they will come out so far until today, only this toxin they got guideline. But on and off they will update. So every few months you go in, they will suddenly add more of you. Last year only half of the substance is here. Now already so many already. They will give you click in, they will show you what is the indication that recommended for HD, or what are the indications that suggested for HD, which means that may be beneficial but depends. They got recommendation, suggestion, then when to stop. Everything is inside. So easy to use as a guide. And to tell the nephrologists also why we ask you to dialyze because of this reason. So the last is urine alkalinization. This one is simple, just to alkalinize your urine. So it's mainly used for salicylic poisoning. Other than that, no other toxin can benefit from this except for salicylic and phenobarbital. But phenobarbital, you can use MDSC. So mainly we use for salicylic only for urine alkalinization. The target is until the urine pH 7.5 to 8.5 without causing a lot of alkalemia in our blood gas. So that's all. Thank you. Any question? That one is case discussion. You want?
The proper fish and everything. Different. Dapat I think sempat
Same only. Of course, you will see some they say don't use choline, all this, but actually never mind. How reliable? Depends on. No, Anissa will say, Dr. Anissa will say like this. Don't trust. They are lying until proven otherwise.
Betul.
Yeah.
Lying until proven otherwise.
Yeah.